morning friends. We are discussing the endocrine system. Okay, let us discuss certain things related to adrenal gland. Okay, we have two adrenal glands above the kidney. Now this is the adrenal gland. Okay, adrenal gland is composed of cortex and medulla. Adrenal cortex, adrenal medulla. Adrenal cortex is divided into three parts: glomerulosa, fasciculata and reticularis. So this is glomerulosa. Okay, so this is glomerulosa, fasciculata, reticularis, and this is the adrenal medulla. Now if we see it mass wise, okay, the 50% is fasciculata. Okay, 28% may be adrenal medulla, 15% may be glomerulosa, and just 7% may be reticularis. So if I ask you the question, which is maximum mass wise? So it is the fasciculata, which is 50% of the gland mass wise. Okay, adrenal medulla is a very small thing, right in the center. Is okay? Now, what is released? What is released? From here, mineralocorticoid, aldosterone. What is released from here? Glucocorticoid, cortisol. And here we have the adrenal androgens. What is released from here? Epinephrine, norepinephrine. Is okay? So let us discuss it one by one. Okay. What is released from glomerulosa? From here, what is released? Aldosterone. Okay. So if this is the gland, this is okay. So what is released from here? What is released? Aldosterone. Aldosterone is the mineralocorticoid. Okay, it is a steroid. So what is the action of this? What is the action of this? The receptor will lie in the cytoplasm. Okay, it is a steroid hormone. So receptor will be present in the receptor, intracytoplasmic receptor, which will go to the nucleus and do the genomic action. Okay, what is the action? What will this aldosterone do? Just see. Sodium will be reabsorbed. Sodium in the kidney. This will go, and in the kidney, sodium will be reabsorbed and potassium will be excreted. H plus will be excreted. These are the three actions. Sodium reabsorbed from kidney, potassium excreted, H plus excreted. Okay, and this action will occur in the last part of kidney, in the collecting ducts. Okay, late distal tubule, cortical and medullary collecting duct. In the last part of the nephron, sodium reabsorbed, potassium out, H plus out. This is the action of aldosterone. Is okay? Now, what is that stimulus in which case the aldosterone is released? So what is the factor who will lead to aldosterone release? Okay, just see. One factor is ACTH, adrenocorticotropic hormone. Okay, although ACTH is meant for this, ACTH is not for aldosterone. ACTH is for cortisol. It is for glucocorticoid. But okay, it has some permissive action. Some ACTH may be required for the aldosterone release. Anything else which will lead to aldosterone release? Angiotensin 2. Angiotensin 2 is again a powerful stimulator of the aldosterone release. Okay, renin-angiotensin system. Is okay? Anything else which will lead to aldosterone release? Low sodium. Low sodium. Okay, hypotension, low BP, low sodium. So when BP will be low, sodium will be low, it will lead to the release of aldosterone through renin-angiotensin system. It can do so directly also. Another is high potassium. If plasma potassium is more, hyperkalemia. So again, that is a strong stimulator of the aldosterone release. So plasma potassium will be more, so aldosterone will be released, so potassium will be excreted, so potassium will be normalized. So it is a potassium regulating mechanism also. It's okay. So these are the 4 factors which will lead to the release of aldosterone from the adrenal cortex. It's okay. Now, actually the question should be, out of these 4, which is the strongest factor? Which factor is strongest? Strongest factor for the aldosterone release. Which one? Angiotensin 2? Okay, angiotensin 2 is most renowned, but that may not be strongest. Which is the strongest factor? It is not mentioned in books, but Guyton suggests it many times that most likely it is the potassium which is the strongest factor. Okay, there are so many sodium regulating mechanisms in the body. Sodium can be regulated by angiotensin 2. Angiotensin 2 itself is a sodium retaining hormone. Okay, but I think this is the only potassium regulating mechanism in the body. So there should be competition. Which is the strongest? I think there should be a competition between angiotensin 2 and potassium. Potassium may be the strongest. Okay, competition. So potassium and angiotensin 2, they are the very powerful stimulator of the aldosterone release. Is okay? What will this aldosterone do? So these are the 3 actions which are done by aldosterone. Done. If plasma aldosterone level is high, more aldosterone, hyperaldosteronism, Conn's syndrome, what will happen? Okay, more sodium reabsorption, so more sodium, hypertension. More sodium means BP more, hypertension. Potassium will be excreted, so hypokalemia. H plus will also be excreted more in the urine, so alkalosis. This is the characteristic of hyperaldosteronism, Conn's syndrome. More BP, hypokalemia and alkalosis. And what will happen in hypoaldosteronism? If aldosterone level is low, hypoaldosteronism, what will happen? Reverse. BP will be low, okay, because sodium is not reabsorbed, so BP will fall. Potassium will be more, hyperkalemia and acidosis. This will be seen in hypoaldosteronism. Is okay? This is done? Okay. Now, what is released from fasciculata? From this fasciculata, what is released? Cortisol. Okay. Just see this. Again, this is the adrenal gland. This is medulla, glomerulosa, fasciculata, reticularis. What is released from here? Glucocorticoid, cortisol. Cortisol is released from here. Okay. Which hormone will lead to cortisol release? ACTH. The main action of adrenocorticotropic hormone is to go to adrenal cortex, fasciculata, and lead to the production of cortisol. Which hypothalamic hormone will do that? CRH, corticotropin releasing hormone. Okay. CRH is released in case of stress, chronic stress. So when you have chronic stress, okay, the CRH is released, ACTH is released, cortisol is released. And this cortisol will do several changes in the body which will help the person to deal with stress. So in which condition cortisol is released? Stress. What type of stress? Chronic stress. Like say you have fracture, so cortisol level will be increased for many days. Suppose you are in jail, again cortisol level will increase. Is okay? Any fracture, any jail, typhoid, any physical or mental chronic stress. Like in animals, suppose you want to put animal, maybe say like guinea pig under stress. Mind it, cortisol will be a biochemical marker of stress. So how will you put a guinea pig under stress? Simple, you break the leg, you cut the tail. Okay, so painful stimulus, any painful stimulus or something like that. Okay, so in case of chronic stress, CRH, ACTH and cortisol. And cortisol will do several changes which will help the person to cope up with stress. Is okay. Now, what is the action of this cortisol? Cortisol, what is the action? What will this cortisol do? So many things which will help the person to deal with stress. Okay. What will happen to protein metabolism? Proteins. Proteins are lysed. Protein are lysed. Okay, proteolytic action. Protein is lysed. Maybe because protein is lysed, so more energy will be available for metabolism. What will happen in fat metabolism? Fat metabolism. Now, very typical thing happens. The fat is lysed. Entire body fat is lysed. But the person eats more. Fat is lysed, but the person eats more. So what will happen? So actually what will happen? The fat will be lysed from limbs, but fat will accumulate here. So ultimately you will develop centripetal obesity. Fat is lysed from every part, but because of the more appetite, fat accumulates here. So you develop centripetal obesity. Okay, centripetal obesity. So you will develop moon face, fish mouth, buffalo hump. Okay, centripetal obesity. Lemon on toothpick. So the person will become like this. A person will become like this. Lemon on toothpick. Okay, centripetal obesity, fish mouth. Abdomen is enlarged and protein is lysed. So what will happen? Large abdomen because of fat accumulation in the centripetal region, and protein is lysed. So abdominal wall, protein in the abdominal wall is lysed. So what will happen? Purple stria. The abdominal wall stria will be produced. Stria, purple stria. Okay, stria is produced. What will happen in carbohydrate metabolism? Carbohydrate. Insulin resistance, just like growth hormone. Insulin resistance, just like growth hormone. Insulin resistance is produced. And when you are resistant to insulin, so blood glucose level will increase. So diabetes type of picture will develop. You will develop a picture very similar to diabetes. And this type of diabetes is known as adrenal diabetes. Okay, you know what is pituitary diabetes? Because of more growth hormone. Another diabetes is adrenal diabetes because of more cortisol. Okay, and pancreatic diabetes, which is diabetes mellitus, we all know that. So even cortisol will lead to the generation of diabetes, and this will be known as adrenal diabetes, because cortisol will lead to insulin resistance and blood glucose level will increase. Another function of cortisol. Okay, cortisol is anti-inflammatory in nature. We all know that. Anti-inflammatory property. Steroids can be used to combat inflammation. So anti-inflammatory action for which cortisol is very widely used. Anti-inflammatory property. Is okay? Another action of cortisol is, cortisol is coming from fasciculata. What is released from here? Aldosterone. So cortisol and aldosterone, both are steroids. So they share some common property. So aldosterone retains sodium, cortisol also retains sodium. So sodium retention, because it has some aldosterone-like action. So sodium will be retained, so BP will increase. So hypertension. Another function of cortisol is sodium retention. Is okay? This is another function of cortisol. So many of the Cushing syndrome patient, they will be hypertensive because cortisol has some sodium retaining property. Is okay? A point worth noting here related to sodium retention. Actually, cortisol goes to kidney and it will lead to sodium retention, just like aldosterone. But just see, suppose this is the kidney, okay? In the kidney, cortisol, it goes to kidney, and in the kidney, it leads to some sodium retention, not much, some sodium retention. In kidney, this cortisol is immediately converted into cortisone. Cortisol converted into cortisone. So it is not able to act. It can lead to sodium retention, but as such cortisol is converted into cortisone. This conversion is done by, who will convert this cortisol into cortisone? Who will convert it? This conversion is done by 11 beta hydroxysteroid dehydrogenase. There is a particular enzyme known as 11 beta hydroxysteroid dehydrogenase. 11 beta hydroxysteroid dehydrogenase. This enzyme will convert cortisol into cortisone, so cortisol won't be able to retain sodium. Otherwise, some retention does occur. Okay. This enzyme is inhibited by, who will inhibit this enzyme? Okay. This enzyme may be genetically, it may be absent, or this enzyme may be inhibited by licorice. Okay, in Hindi we call it as mulati. In Ayurvedic they use mulati to treat cough. Okay, it is a sweetener. Licorice is a sweetener. So this is inhibited by licorice. So if you will eat much licorice, what will happen? This will be inhibited. So this will not be converted into cortisone. Therefore, cortisol will act more. Cortisol is not converted into cortisone. So cortisol will act more. It will retain sodium. So BP will increase. Is okay? Cortisol retains sodium, but it is not able to retain sodium because it is immediately converted into cortisone by this enzyme 11 beta hydroxysteroid dehydrogenase in kidney. But if this enzyme is inhibited by licorice, okay, So cortisol will not be converted into cortisone, cortisol will retain sodium and BP will increase. Okay, and this condition may be known as apparent mineralocorticoid excess. Apparently mineralocorticoid appears as more, sodium is retained, just like as if there is hyperaldosteronism. So this condition is known as apparent mineralocorticoid excess. Apparent mineralocorticoid excess. Okay, BP will increase. Another point worth noting, if you will eat more licorice, if you eat mulati, okay, licorice in Hindi, this is known as mulati. If you eat mulati, BP may increase. Why BP is increasing? This is because of the apparent mineralocorticoid excess. So this term is used for the more sodium retention because of more cortisol. Okay, this enzyme may be congenitally, this may be weak also. Okay, so what is the function of cortisol? Carbohydrate, insulin type of function, insulin, diabetes type, insulin resistance, and fat is lysed from limbs, abdomen more, so centripetal obesity. Protein is lysed. Everywhere protein is lysed. Protein is also lysed in bones. So if bone protein will be lysed, bones will also become weak. Okay, bone osteoporosis, bones will become weak. Anti-inflammatory action, and another is BP, sodium retaining action. These are the actions of cortisol. Is okay, and somehow these actions, all these actions, they will help the person somehow to deal with chronic stress. This is okay? This is fine. If cortisol level is more, what will happen? If cortisol level is less, then what will happen? More cortisol. If cortisol is more, glucocorticoid more, what will happen? Cushing syndrome. Cushing syndrome. If cortisol is less cortisol, what will happen? Addison's disease. More cortisol is Cushing and less cortisol is Addison's disease. So what will happen in Cushing syndrome? You can very well imagine. Protein will be lysed, abdomen will be more, there will be purple stria, bones will be weak. Okay, because of the proteolysis, there may be slight hypertension also. This okay? There may be diabetes type of state also. Just you can imagine what will happen. This okay? What is the difference between Cushing's syndrome and Cushing's disease? Cushing's syndrome and Cushing's disease. Now just see this diagram. If this is more, cortisol is more, Cushing syndrome. Okay, there may be some tumor over here, some sort of adenoma, which is releasing cortisol, so you are getting Cushing syndrome. Just imagine that Cushing syndrome is because of ACTH secreting pituitary adenoma. Then what will happen? Suppose tumor is not present in adrenal, it is present in pituitary, which is secreting more ACTH. So cortisol is more, so you are getting Cushing syndrome. So this condition is known as Cushing's disease. So Cushing's disease, this is the cause. Cushing's disease. So Cushing's disease is the Cushing syndrome because of pituitary cause. Is okay? Usually in Cushing syndrome, cortisol is more, ACTH is less. This is Cushing syndrome. In Cushing's disease, cortisol will be more, ACTH will also be more. This is Cushing's disease. This is fine. Because the cause here is not adrenal, cause here is pituitary. So here both will be more. Here cortisol will be more, but as a feedback ACTH will be less. What will happen in addition? Cortisol is less. So as a feedback ACTH is more. Don't forget, ACTH has a very similar action to MSH, melanocyte stimulating hormone. Is okay? POMC. POMC, pro-opiomelanocortin. Pro-opiomelanocortin is the common precursor of opioid. MSH and ACTH. So ACTH and melanocyte stimulating hormones, they share some common action. So ACTH has some MSH like action and ACTH leads to pigmentation. So in this condition ACTH is more, in this condition ACTH is less. So in which condition you will get pigmentation? Addison's or Cushing's? Addison. So in Addison's disease you will get pigmentation, not in Cushing's. Suppose you are getting pigmentation in Cushing syndrome, what will that indicate? That will indicate Cushing's disease. Okay. So Cushing syndrome associated with pigmentation indicates Cushing's disease. Okay. So pigmentation will be seen in Addison's disease. It will also be seen in Cushing's disease, not in Cushing syndrome. So Cushing's disease is the Cushing syndrome because of problem in pituitary. Simple. So if it is more, Cushing's, if it is less, it is Addison's. This is the function of, clear? This is the function of cortisol. Now, another hormone which is released from here is from adrenal medulla. Again, what is released from adrenal medulla? Another thing let us try to discuss. This is adrenal gland. Okay. What is released from adrenal medulla? Norepinephrine, epinephrine, okay, dopamine. 90% is epinephrine, 10% is norepinephrine, and dopamine just negligible. You can remove this also, negligible. So what is the main output from adrenal medulla? Epinephrine. Okay, not norepinephrine. Epinephrine is the main output. What is the main output from sympathetic terminals? Sympathetic terminals, what is the main output? Norepinephrine. But adrenal medulla, epinephrine. 90% of the output is epinephrine. Is okay? So sympathetic terminals, they release norepinephrine and adrenal medulla releases epinephrine. What's the difference? Is there any special difference because of that? Any special action which you have achieved? Just see. How these catecholamines are synthesized. Just see. So they are synthesized from, just see, phenylalanine. Phenylalanine is converted into tyrosine. Tyrosine is converted into dopa. Dopa is converted into dopamine. Dopamine is converted into norepinephrine. And norepinephrine is converted into epinephrine. This is the sequence. This final step, conversion of norepinephrine into epinephrine, is done by which enzyme? PNMT. Okay, it is a methyl transferase. Okay, and methyl transferase. So what I want to say that in sympathetic terminals, reaction will stop here. But in adrenal medulla, reaction will go one step further. Okay, because in adrenal medulla, this enzyme is extra enzyme which is present. So in adrenal medulla, this reaction will go up to this level. Okay, in adrenal medulla, we have PNMT. In sympathetic terminals, we don't have PNMT. Adrenal medulla is trying to become slightly more smart. It has one extra enzyme. So what is the benefit of that? By possessing this extra enzyme, what benefit adrenal medulla will give you? So just see. If I give norepinephrine infusion to the patient, what will happen? Norepinephrine has a peripheral alpha action, alpha receptor, peripheral action, vasoconstrictor. Okay, because of that peripheral vasoconstriction, systolic pressure up, diastolic pressure also up, mean BP up, BP, because of alpha action. Systolic up, diastolic up, mean BP up. Is okay. What is the action of norepinephrine on heart? On the heart, we have beta 1 receptor, and because of beta 1 receptors, the heart is stimulated. Okay, so heart rate should go up, stroke volume should go up, cardiac output should go up. But the point worth noting here that the BP is increased. So what will baroreflex do? What will baroreflex do? Baroreflex will try to inhibit the heart. Now, direct action is stimulatory because of the beta 1 action, but indirect action is inhibitory. So which action will predominate? Direct stimulatory action through beta 1 receptor or indirect action through baroreflex? Which action will predominate? Indirect action will predominate. Therefore, heart rate low, stroke volume low, cardiac output low. Okay, heart is inhibited. Heart rate, stroke volume, every modality of the heart is inhibited. Heart is slow, then why BP is high? Because total peripheral resistance has increased so significantly, TPR. Total peripheral resistance because of the peripheral vasoconstriction is increased so significantly that despite compensation by heart, BP is more. This is norepinephrine. Okay. What will happen with epinephrine? What will happen with epinephrine? Okay. Now, epinephrine has peripheral alpha action, which is vasoconstrictor. Okay, just like this. Epinephrine has a very special peripheral beta 2 action, which is vasodilator in skeletal muscle. So it will do vasoconstriction everywhere, but vasodilatation in skeletal muscle. Okay. So in the entire body, vasoconstriction is produced, skeletal muscle vasodilatation is produced because of beta 2. So what is the net result? What will happen to total peripheral resistance? It will increase or decrease? It will decrease because beta 2 action, skeletal muscle is a big tissue. Beta 2 action is more prominent. So total peripheral resistance is decreased slightly because of beta 2. Although beta 1 is constrictor, but still beta 2 action is quite prominent. So TPR falls. What will happen to BP? What will happen to BP? Total peripheral resistance is low, therefore diastolic is low, but systolic is more. Mean blood pressure is slightly increased. This is BP. This was TPR. Now just see. Mean blood pressure is not that increased. Mean blood pressure is only slightly increased. So what will happen to heart? It will be stimulated or inhibited through baroreflex, because mean BP is not that increased. So direct beta 1 action on heart will predominate. Therefore, heart rate up, stroke volume up, cardiac output up, everything up, whether it is heart rate or stroke volume or cardiac output. Because stroke volume is more, that is why systolic is more. TPR is less, that is why diastolic is less. Is okay? So this entire thing is epinephrine and this entire thing is norepinephrine. Is okay? So this is the diagram very clearly given in book, and many times the questions are framed on this. Cardiovascular difference in the action of epinephrine and norepinephrine. Is okay? So pulse pressure is increased in which case? Epinephrine or norepinephrine? Very common question. Pulse pressure is increased with epinephrine, not the norepinephrine. Is okay? TPR will fall in which case? The TPR will fall with epinephrine because of this action. Is okay? So this is a very clear-cut diagram given in book, and question may be asked. So now, can you tell me in which condition, this epinephrine is released by adrenal gland, this is released by sympathetic terminal. So by releasing epinephrine, by converting norepinephrine into epinephrine in adrenal medulla, what is the benefit you are getting? What extra benefit you are getting? This beta 2 action. Because of this beta 2 action, what is the benefit which you are getting? Increased skeletal muscle blood flow. This is the benefit of epinephrine. Increased skeletal muscle blood flow. Okay? You are preparing yourself for fight or flight. In case of acute emergency, okay, this is beneficial norepinephrine, no doubt. It will increase BP and it will make you more alert. But this will give you more benefit. This will increase the skeletal muscle blood flow in advance. So it will prepare you for fight or flight reaction. Norepinephrine will help you. It will prepare you half. This epinephrine will prepare you fully for fight or flight reaction. Is okay? So by increasing the skeletal muscle blood flow, epinephrine will give you several extra advantages. Is okay? So sometimes questions are framed on these differences. Is okay? So maximum part of the adrenal gland is now discussed. Okay? Many of the things they are discussed at the clinical level, but the basic physiology has been discussed here. Okay? Thank you.